Good morning. Today I'm going to talk on about systematic review that we performed recently on the management of neuropathic pain in patients with undergoing amputations both in the hand and in major limb. This is a collaborative research between Europe and in Asia where we combine resources to conduct this systematic review. Amputation pain is common, as seen as about 8% in finger amputation and up to 85% in major limb amputation. The pain in amputation can be due to residual limb pain or specifically due to phantom limb pain. And in this systematic review, we looked at this post-amputation pain as our outcome measure. The aim of this systematic review was to understand the various surgical techniques that have been performed in the literature for neuroma prevention and which was the best method to produce minimal pain post-operatively. We used the standard methods for systematic review, in which a literature search was performed on the 26th of March 2021 with these various databases as shown here, and the PICOS framework, which you look at later, and the search strategies are available for those who want to see the exact search mechanisms that we use. And we used the PRISMA guidelines. Selections was performed with quality assurance between researchers to ensure there was quality maintained, and selection was performed with data extraction based on our criteria, and synthesis was then performed on the results. This is the PICOS framework that we used. The population were those patients undergoing amputation. The intervention was any specific surgical methods being used to prevent neuroma or pain post-operatively, and the control were the standard management of nerves during amputation. The outcome measures were neuropathic pain post-operatively, and the study design was to ensure that there were clinical studies with more than 3 patients. So the selection criteria mainly they included was when there were measurements of neuropathic pain post-operatively, these studies were included. There was need to be a mention of the prevention method during surgery for neuroma prevention, and the surgery had to be primary amputation surgery. To ensure quality control, data extraction was performed in accordance with the Oxford Centre for Evidence-Based Medicine, where we ensured there was pain measurement was being done post-operatively with specific measures, and the outcome measure was the prevalence of residual limb pain or phantom limb pain. The various recommended tools for the assessment of quality of each of the papers were assessed, and here is the example of some of the papers that was evaluated for observational cohort studies, and these were the questions that we used, the 14 questions that were used to assess the quality. Here is the similar type of assessment using the recommended tool for case series studies. These are the papers, and this is how we assess for qualities based on the 9 questions on the quality of the studies. So this was the PRISMA flow diagram from the our search. We had 6,000 over papers, which was then following removal of duplication, we had 3,281 records that were available for assessment, and these were then reviewed for eligibility, and we obtained 13 papers that fulfill our inclusion criteria, which were then used for data extraction for qualitative evaluation of the results. Quantitative evaluation was not possible in this systematic review due to the heterogeneity of the data, and therefore a qualitative synthesis was performed. So this again is the diagrammatic representation of the surgical techniques for neuroma prevention in the fingers, ranging from neurovascular island flap to central union, which is basically coaptation of the nerve ends of the amputation, and epineural ligature, or the use of an epineural flap to suture the ends so as to prevent neuroma, and the use of epineural graft to cover the raw ends of the nerve. These are the details of the studies for finger amputation, showing the various studies, the types of pain that was being recorded, and the number of patients that were available. For major limb amputation, these are the various surgical techniques. In major limb amputation, one of the popular techniques is targeted muscle re-innervation, which is to take the nerve from the amputated part, the major nerve, and to suture it to the end of a neurotomized motor nerve to the stump and this is targeted muscle re-innervation. The next is targeted nerve implantation, is to take the amputated nerve and to then bury that amputated nerve into the end of a neurotomized nerve to a muscle, and therefore the growing axons will get buried in the muscle. The technique that was used for the major limb amputation was the coaptation of the ends of the major nerves in the stump and then wrapping that with a kind of tissue to prevent any axons from leaking. This can be autograft like muscles or even allografts like various synthetic materials. Finally, for regenerative peripheral nerve implantation was a technique in which the nerve stump was wrapped with muscles obtained from the limb, and then this was then implanted into the muscle. The muscles provided a cap to prevent axonal neuroma formation. Another technique used in hand amputations and digit amputation especially was the targeted muscle re-innervation of the amputated finger using the nerves quite similar to targeted muscle re-innervation. These are the results that we see in the qualitative synthesis of the various types of surgery for neuroma prevention with the forest plots showing some of the studies where statistical significance was seen in the analysis. So the implication of this systematic review is that for finger amputation, central union, that is the suturing of the nerve ends to each other in an attempt to prevent neuroma formation was useful. This is a technique that would be recommended based from this systematic review for finger amputation. For major limb amputation, they found that all the techniques that were described in this systematic review were useful, be it targeted muscle re-innervation, nerve implantation, concomitant nerve coaptation, or regenerative peripheral nerve implantation. And also we found that in this systematic review, there was a pain medication use ranging from 16% to 50%. So the limitation of this study is therefore the different descriptors for pain and outcomes in the study produced so much of heterogeneity was very difficult to compare. This significant heterogeneity precluded meta-analysis, and that is why we chose qualitative synthesis. Standardized outcomes for the measurement of subjective and objective results from amputation needs to be done in future studies, and we recommend the use of the Lance pain scale or the DN4 instrument to measure pain. Furthermore, I think it is important in amputation as they got significant psychosocial and economic impact. A qualitative outcomes should be measured primarily in patients with amputation. We will discuss this later in another paper. Thank you.